Here today. Hello, ladies and gentlemen. You are all welcome to today's meeting. Today is another great day, and we have our very seasoned, exciting personality in our midst. He is going to be discussing every questions that borders on documentation in the nursing profession. First, he's going to be telling us about his journey. He is a Nigerian-born registered nurse, trained in Nigeria, immigrated to the United States, now an American citizen. He is doing exploits. He is doing exploits. When I say exploits, I mean it in every bit of that word. He is doing so great for himself, for his family. I mean, I've been to his house, I've been to his place. The last time I went to Texas, I visited him, and I know when I tell you that he's someone that can mentor people, he's someone that can teach people, is someone that can pass information to others. I mean it when I say that. So he's here and he has been in this show before, but just in passing. And that day he came, he actually dropped a bombshell, and I was like, I'm going to follow you up until you come to this show. So today we were happy that we have been able to get him. And let me tell you guys, it is not easy to get a hold of him. In fact, to get him today, I felt like canceling the show in the middle of this whole thing because he hasn't taken a nap. He hasn't slept. Like, he came out from a shift and he is here because he values the act of passing information to people. He values it. And everybody I bring to this show, I always tell you guys, we don't pay for this program. People are not being paid to be here. But anybody you see on any of our flyer, you know that those people have passion to pass information to the younger nurses or people who are in a journey that they have been through. So, ladies and gentlemen, I want you to welcome our distinguished guest. And he's so humble that I kept on asking him, allow me to put your qualification. He's like, just call me Samuel Adejuwon. Okay, ladies and gentlemen, allow me to welcome our distinguished guest of honor, a man of service, a humble man to the core. Samuel, you're welcome to the program today. How are you doing?
Thank you very much, my chief. It's a pleasure to be here today, sir.
Honestly, it is our own pleasure to welcome you to this meeting because of the sacrifice you put to it. And I'm so excited that you're able to make it. We have over almost 80 people on the show right
Oh,
now that are listening from different parts of the world. I have people from Kenya, people from South Africa, people from Zimbabwe. So it's not just Nigerians. We have a lot of people from all over the place, and we are all here. Our common goal and our the common denominator for all of us is that we are all registered nurses, and we are on this journey of immigrating to either United States, Canada, UK, but any of those advanced country where documentation is important. So we want to start off this year with learning the basics of things that will help us to keep our license safe. Even when we pass our NCLEX, we want to still make sure that our license is secured. So today I'm going to turn it over to you. I want you to just help us and do an introduction. I know you got some accolades. If you would please kindly just let us know. It's not being proud, but just to encourage people that are following you, that are listening to you today. Okay, so let us know your journey, how you came to the United States, where you've been before you came to the United States, and then you can now share your slide and then hit the ground running, like our president would say. All right. Thank you and welcome to the show, Mr. Samuel.
thank you very much, boss Decency. Once again, my name is Samuel Adejuwon. Uh, it's a pleasure to be here today. I was here a few weeks ago in one of the programs while I joined my brother, Dr. Ogundare Johnson, who was having a presentation then, and eventually, boss Decency brought me up. I shared one or two information, and as the chief says, I have to come back and speak more. So, and here I am today. It's a great privilege, and I'm optimistic that we're going to benefit from this session. Uh, like you said, I'm Nigerian, of course, from my accent. More precisely, I'm an Ekiti man. So I'm from Ekiti State. Uh, I don't know. Can you all see my screen?
Yes, we can.
And is it full screen, sir?
Yeah, it is.
Okay, cool, cool, cool. So I'm going to talk about myself in the course of this conversation. Most importantly today, I have a few slides to share, and a way to summarize the whole thing will be through questions and answers, so we can clarify some things. The boss told me we're going to be talking about nursing documentation. Of course, that is part of clinical and cultural transition. Once again, Boss Decency, thank you for this opportunity. At least I've known you for about 8 years now. The first time I got in touch with you was when I was trying to get my fingerprint card, I think 2017, 18. So, and since then, we've been in touch. And look, glad I was able to see you sometime last year, and hopefully we'll see some more. I'm a registered nurse here in the United States. I also worked in the United Kingdom as a registered nurse for about 2.5 years before getting here. That should just take me to my next slide. Becoming a US RN. I'm sure more than half of us here today are already, I mean, would either be on the path of becoming US RNs or are already US RNs, just waiting for the due dates, which it comes to next. We know the process, of course. There's a pre-NCLEX phase. My own story was the Philippine story. We know the whole process, and at the end of it, you need to go write the NCLEX out there. Unfortunately, in those days, we had less centers or less opportunities in Africa. So Philippines was one of those surest locations. So I jumped on that train, went on to Philippines, did the needful, and I came back. But it was a really unforgettable experience. For those who have passed NCLEX, I believe you understand what I'm talking about. The anxiety that comes with after the exam and you don't even know what's going on. Of course, post NCLEX phase, people always assume that uh, after NCLEX, the next thing is to move. But I can't, like we know what's going on now. In most cases, it's beyond that. There are delays, there are setbacks. And I call that the post NCLEX phase. For me, I had RFEs. I don't think RFUs are common again these days, unlike then.
No,
You
it's
see
not.
people have
It's
you see
not.
people have yeah, so you see back then people could have maybe two denials of the I-140 and then maybe three RFEs before they finally get some approval. So I think I had two RFEs and one denial. Coincidentally, the day I got denial was the day I stepped my feet in the United Kingdom. So I just looked at the email and I just put it aside. So, of course, COVID also contributed to my delay. While the delay was going on, I took the opportunity to develop myself professionally, personally, and I'll say financially in the United Kingdom because I had what it takes, and that was an opportunity. So, that was where I faced my series of shock, culture shock, and clinical shock, so to say. After the preparatory phase in the United Kingdom, I go to the United States. I was in Florida for a few weeks because I told my agency back then when they were asking me for my choice location, I said I wanted Texas by all means. Out of three or five options, I think first three options were Texas, 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 then Virginia, and one other state. Luckily, I got the Texas state I wanted. So, and I've been in Texas since then. So I'm based here in Texas, more precisely around Houston. Uh, let's jump on to what we're talking about today. Before I'll try to link the clinical documentation, nursing documentation to culture shock and cultural adaptation. Because clinical documentation or nursing documentation here in America is sort of shock is something that we need to transition into. We understand the meaning of culture, of course. It's just the general way of life of people, the way people eat, the way people dress, the way people talk, different things. And so because it is not our way, it is their way. We're trying to get into it. Therefore, there is this friction that happens, something we're not used to, trying to get used to another person's way of life, trying to inculcate that into our own lives. And there are phases of this, as described by Olberg in 1960. There's a honeymoon phase. That's when you eventually get what you've been looking for. You want to get to the United States. You want to go to the United Kingdom. You want to go to Canada. Eventually, you get it. Now you are here. What's the next thing? So the first thing you feel is that excitement, and that's the honeymoon phase. After that, then the real shock hits you. That comes with some frustration. After the shock, of course, you get some adjustments. You understand what's going on, see things differently, and gradually you are keying into the routine before you eventually get into acceptance phase. Remember this topic in nursing school in those days when you talk about stages of grieving, where you have the I can't remember the student again. I think denial, anger, till you get to acceptance. So this follows a similar pattern. You might jump around, but eventually you have to go through these phases. And I must tell you, going through these phases uh, is very important. Without going through these phases, without getting to the final destination, which is the acceptance phase, people may struggle. We'll get more into that in the course of this conversation. I hope we are getting some points.
Yes.
Okay, good, good. And like I said, the final phase is the acceptance phase. At that point, their way of life is now your own way of life. You are part of them already, and you continue to develop like this gradual normalcy. That is what referred to as the adaptation itself. There are elements of this shock. Basically, we're going to talk about uh, cultural shock and clinical shock, so to say. So the culture is just talking about things that happen outside, like outside the work environment. You talk about the weather. Of course, we know what happened in the past few weeks over the weekend where some states had to shut down completely because they saw some snow. Whereas some actually just carried on their way of life. Like it wasn't nothing serious. You talk about the food, what we have in Africa, what we used to eating in Kenya, in Zimbabwe, will be different from what you have here. Of course, depends on where you stay or where you live, where you find yourself in the long run. You can still have access to those things, but might not be immediately you get in. So that shock, that transition is inevitable. Of course, the language, yes, it is English language, but I tell you, there are accents. The way a Texan will speak will be different from the way someone who comes from maybe Louisiana will speak, or someone, or the way a New Yorker will speak to you. They speak in English. People in the UK will understand this better. The accent in UK, you have the Welsh accent. If a Scottish speaks English to you, it sounds different from when someone who lives in Liverpool speaks English to you. And then you wonder, are these people actually speaking the same English? But yes, it is. So these are part of the things uh, you will experience. Sometimes in the hospital environment, you also see this. Imagine you work in, say, you find yourself in Virginia, and then you have a patient who is from Liverpool. Now you've been in the state of Virginia, you've been working for some weeks, you understand the accent gradually. And then you meet a patient one day who speaks completely different, not even from the United States this time around, maybe from Liverpool. And then you wonder, of course, they're still going to make their needs known to you, and you have to fulfill those needs. So language and accent are one of those elements of the uh, cultural shock we're talking about. Of course, housing is there when you think about monthly allowance and some utilities. Remember back home, we most likely don't pay our rent monthly. Maybe you pay once in a year or something, but here you have to do it on a monthly basis. That is a sort of shock because it is something different from the usual, different from the ordinary we're used to. So such must also be mentioned. Of course, people's values, their beliefs, time management, which you see mentioned later on, holidays, and a host of other things. Just think about different things that are different from where you're coming from, that are outside the work environment. That's what we refer to as the cultural aspect of this shock or the cultural element in this transition. Uh, Next year, I'll be talking about the clinical elements, that is, things that are more particular to the work environment. The first on my list here is talking about brand names and generic names. A friend of mine came from the UK a few months back. He worked in an ER here in the States. And I think probably the first few shifts he had, he was so lost. Why? I think they brought in a patient to him to the ER who was having some seizures. And then there was order for Ativan. And they kept asking him, get some Ativan, get Ativan. He was lost. Why? Because he didn't know what Ativan is. To him, it was Ativan. That's Ativan. But to someone else, it might be a different medication. What am I saying in essence? They were asking him to go get some lorazepam. But because they didn't call it lorazepam, which is a generic name, they called it Ativan, which is the brand name. That threw him into some confusion. This could be you. What am I saying in essence? Here in the United States of America, they use more brand names in the clinic settings, in the work environment, than generic names. Don't be scared. I'm not saying this to scare you. You get used to it in no time. My own story when I came in back then, I was so confused and I was like, I think I need to make a long list of common medications that they use the brand name and then but lo and behold, I didn't do any of those things. And today I think I can flow well when they talk about those medications in terms of brand names and not even the generic names. Maybe Boss Decency understands why they do that. But sometimes I look at those medications, I think Americans want the easier things. So when medications have long names, they just give it some short names. Back in the UK, we used I think we used to uh piperacillin tazobactam. But here in America, I just said give some Zocin,
Those
give Zocin, give Zocin. So that's just by the way. Just get ready. One of those things you see. So you have to just prepare your mind. This is going to happen to you. Then part of your adaptation, part of your uh culture change cycle is understanding these things and getting a way around it. We also have patient identity, of course. Most of us are from Africa. We understand how not to call people by their first name. Rather, you say Mr. just out of respect. But here in this part of the world, people actually prefer their first names and you call them by names, no Mr. Just go ahead and call them. Patient identity, talking about HIPAA, that's when you have to, that's the Health Insurance Portability and Accountability Act. That's a big deal where you don't just divulge patient information to anybody over the phone. Anybody, this is America, anyone could pretend to be someone else on the phone and then try to get information about a patient. So you have to prepare yourself. Such things are rampant here. HIPAA is a big thing, is a big deal. Nurse patient ratio. Uh, I don't know where we work back home, but I've experienced things. I've worked in locations whereby I had patient ratio of 12 on a night shift, one nurse to 12 patients. I've seen. 1 to 10. I've worked the 1 to 6. But sometimes I feel I'm enjoying my best nursing era at this time. Currently, I work somewhere where I have just 3 patients. Sometimes I might be lucky to have two. I don't work in ICU. Don't get it twisted. But it's just what it is. So so I tell myself I'm in my best nursing era. So nurse patient ratio. And let me just say this, some of these things might also vary based on our location here in the States. In the same state, you could also have different uh nurse patient ratio. You could have some of these things that vary even in the same state. Remember, this is a very big country. Some states could be as big as maybe a country outside there, or maybe half of a country. So things also change even within the same state. We also have this uh pandemic, or we have this endemic of Dr. Google, where the patient and the relatives are actually healthcare providers. You're talking to them about something, they're on their phone. Before you get back into the room, they've gone to the internet, they've gone on Google, they used AI to find out about those things and expect it to probably come and say what is wrong, or just you understand what I mean. So just saying this so you can understand some level of preparation and readiness you need to put in. Tardiness is a thing here, unpaid breaks, the flexible scheduling. With flexible scheduling, you can you have the opportunity to actually determine your own schedule. Back home, it doesn't happen that way. At least when I was there, it wasn't like that. You you follow what has been scheduled for you. You have options of making some basic requests. But here, or in most places, uh, when you are in the system proper, there are periods in the schedule where you can go online, go and plot in your schedule. In most cases, if you follow the rules, you could get maybe 98% of what you have requested for. Maybe you moved in one place or two places. So that's one thing. And sorting actually makes work-life balance easier. All right, I think I'm staying too long on that slide. Let's jump on to the next one. Uh, there's also complexity of cases. Remember all those things we used to see in the books, in literature. You could have a patient that combines probably 6, 8, 10 comorbidities. And then you're like, what am I going to do first? That's when our knowledge of the application of our knowledge from NCLEX, prioritization, that's when those things come in. People here in most cases are not people that come down with malaria. Back home in those days, when people come in, what do you think of first? Malaria and typhoid. Go and do NPY now. So here it's different. You see people come in, they write down loads of diagnostics, CMP, like complete metabolic panel, I mean comprehensive metabolic panel, you do chest X-ray, you do UA, you do drug screen, just a lot of things different from what we are used to. That's because these people are complex, or some of these cases are very complex, and an individual can come down with a lot of those cases in one. Of course, you're going to treat this person as a being. You're not separating any part of this person. So you need to have a clearer picture. Of course, there's multidisciplinary team here. Of course, like every other place is trying to, I think it's evidence-based practice, so to say, and everywhere around the world, trying to uh, upgrade standards to meet up with multidisciplinary team with distinct roles. There's a culture of safety, which is very key as well. Communication, which actually take us to the next thing. The communication could be verbal or non-verbal. Of course, when you pass on information from one person to another, from one institution to another, that is when we're talking about documentation. You could do that over the phone. That's you can communicate over the phone. But when it becomes your word in your absence, what you have said, what you have done in your absence. That's the meaning of documentation. That is, what have you written down? And today we'll be shedding some light on some of these things about documentation. I put something here that the nurse is everything. Yes, the nurse is everything because you could get into a patient room and then the relative sees you as the nurse. You are the first person they see. They want this, it is you. They want this, it is you. Uh, they want to talk to the doctor, you're the first person they see. They need a physical therapist, you're the first person they see. I need some water, you're the first person they see. Probably because of societal uh picture of the nurse. It is your responsibility to then delegate. So you're not actually the all in all. That is the concept of delegation. In most cases, they don't actually relate with those people, but they come to you straight. They talk to you straight. Then it is your own responsibility to uh, delegate and actually divert their request to the appropriate channels. Oh, okay. I think I have one more here. Having talked about these different things in terms of shock and changes which might expect in the clinic environment, outside the clinic, that's cultural. How this will affect us in several ways. It could be physical, you'll be fatigued, you could have some sleep disturbance, might be anxiety, depression, homesickness. Those are the emotional influence. Could also be cognitive when you are frustrated because things are not going the way you expect. You feel out of place. These are some of the things that happen when we are in this phase of culture shock. Of course, there are way forward. Like you manage your expectations. You don't actually expect perfection. You might get to a system and then you see some shortcomings. That is why it is not a perfect system. There's a room for improvement. Just the same way we are also improving ourselves. You need to keep an open mind. You need to immerse yourself, explore, try out things, learn things. You don't just come with the African mentality, so to say, and then stick to the African mentality. You need to try out things, learn people's ways of life, because this is going to be your home for a long time. You need to build network. You're not, you don't live, you don't work in isolation. Those are some of the way forwards that I itemized here in dealing with the culture shock. Maybe when we get to question and answer, we can explore more on those things. Remember, I talked about documentation, and now we're going to talk about how to adapt to nursing documentation. We've been documenting as long as you've been a nurse, you've been documenting. Here, we're going to talk about maybe how it differs from what we are used to, or some basic tips that can help us, that can prepare us for when we get in. Some of these things you can actually start practicing wherever you are. By the time you practice these things, you incorporate these things in your routine. By the time you get in, it's already part of you, it becomes a habit for you. I think American Nursing Association, Nursing Association defined nursing documentation as the accurate and timely recording of patient care to support safety, continuous and legal accountability of practice. Look at the keywords there. It's it must be accurate, it must be timely. And what is the purpose? You're talking about patient safety. You want to support patient safety. That's if you have cared for a patient. You are no longer there. How will others see what you have done? That is your documentation. Remember, if it is not documented, then it wasn't done. If after you've left your 12-hour shift or after a whole week, probably you're on PTO, you don't expect anyone to start calling you. Did you give this medication? Did you do this? If it is not documented, it wasn't done. You need to hold that. Of course, we know that that's not new to us. So, uh, I think when you document, they serve as legal records for up to is it 7 years or 10 years. Decency.
I think it's
I
10
think it's about
years.
10 years. So
Yeah.
that is whatever you have done. Okay, imagine you have a patient today. This is January of 2026. And maybe in 5 years' time, probably you are even an NP, you don't work at the bedside anymore, or you've even left nursing for us. And you have your business. And then now probably something uh came up and you are called upon because you took care of a patient. Tell me, can you remember the patient you took care of 5 years ago on this day, 5 years ago? It's almost impossible. But one thing that will speak for you at that time is your documentation. And that is why we have to take it seriously. It is professional, it is legal, and it is our ethical responsibility to document and document right. The importance of this documentation or of accurate documentation is essential part of patient care, of course. And incomplete documentation simply means incomplete care. If you haven't documented it, you haven't done it. Don't say because you want to document it and then you don't do it and you document it. That's also that's false. It means you are falsifying information. It helps to promote safe patient care. It ensures continuity of care. That is, you are out of the unit, you are out on vacation, but people are still there going through what you have done. They can see what you have done and they can continue from there. There's no repetition or duplicating care. It serves as legal evidence of care provided. That's what I mean by after 5 years or after 10 years, they can still go back to what has happened and bring it up. What is written down, we speak. What you said you have done or what you have documented is what you have done. If there are errors there, they're going to pick those errors up. If there are false information there, those false things will be seen one way or the other. And with this age of electronic system, it makes it easier for system to pick up to identify odds. It also supports quality improvement and evidence-based practice, of course. And very importantly, accurate documentation is required for reimbursement and compliance. Reimbursements, not for you, but for the hospitals. And that's why hospitals don't play with it. They don't joke with it. In fact, some hospitals actually have, I think, clinical documentation specialists. After you have documented, what those people do is they go through those documentation to like maybe iron them out, identify some faults. You could go off your shift, and after, okay, let me give you a story. Imagine you had a patient, then 3 weeks down the line, this patient was moved to another unit and maybe develops a central line infection. The central line has been there since the 3 weeks you had a patient. What would they what would they do at that point? They will start back tracing this thing. Where did this error occur from? This patient came into the hospital, the central line infection wasn't there. Now, after 3 weeks, it is confirmed that this patient has a central line infection. It is nosocomial, it is hospital acquired. They need to find out where it started from. They need to trace it to the root as much as possible. Imagine you had this patient and then you were meant to do a chlorhexidine wipe, a special wipe to clean the patient to reduce chances of infection. And then you did it, but you didn't document it. When they get on your chart, on that date or the time, you did it. You had witnesses that you did it. You didn't do it alone, you did it with people. But unfortunately, you didn't document it. It means you didn't do it. They could actually say your omission of your responsibility of care at that point is one of the causes of that central line infection. And how will you justify yourself since you haven't documented it? What am I saying in essence? Accurate documentation is essential. We need to start practicing it. We need to start learning it. So this can be part of us. We're almost getting there. Don't worry. So we can get to the question. I think the question and answer part is always a very interesting aspect of the gathering. So we'll get there in no time. The next thing I have here is principles of documentation, the methods. What are the principles? What are the For you to document, you need some things that must be present in your documentation. It must be simple. You need to be accurate. It must be timely. That is, you do it as soon as possible. Don't get it mixed up. Sometimes you might be busy, you have done it, then something happened, you're not able to do it, to chart it at that very time. That's possible, that happens. There are ways around it. But as much as you can, you should try to document these things. You should try to put these things down as close to when you have done it as possible. That's talking about the timeliness. Your documentation must be objective, it must be clear. Of course, we have said that they can pull this thing up after 5 years, 7 years, and you can't even remember what you documented then. If it's not clear, imagine you were trying to write maybe you wanted to write, I can't think of something, but maybe due to error, maybe spelling errors or something, it changes the whole idea of what you are documenting. Always remember there must be clarity in your documentation. Of course, there is a room for consistency and standardization. You don't use unapproved abbreviations. There's also need for confidentiality when you document. Where necessary, you avoid putting patient identifiers. And when it is needed, you make sure you include such identifier. That is HIPAA. We mentioned earlier that HIPAA is a big thing here in America. People could get fired because of that. And that can happen in different means. I'm sure we have seen stories or we have heard stories of how these things happen. Someone can pretend to be someone else, can impersonate over the phone. You divulge information, and then you're in big soup. Hospitals don't joke with it because some people are out there. All they want to do is they want to sue. They are ready to sue because of the money they will get from it.
Exactly.
So as much as possible, you won't be a victim, and you have to do what you have to do so you are not a victim of such. All right, let's move on. This is another interesting aspect. You're talking about the methods and the formats of documentation. Documentation is simply what you have been doing back home, right? Your patient has a fever, you do this tepid sponge.
Mhm.
You do this, you give this medication, you document those things. But here, it might be different. Even if you have done the same thing, but how you write it down might be different. Why? Because of electronic health records. Uh, Electronic health records have been opportune to actually use the major ones here in the States. When I got in at first, I used Meditech. That happened to be like the best thing that happened to me, coming from paper charting to computer-based charting, which was Meditech. I loved it. And then I changed hospital. I used another version of Meditech. I was like, these people are living in they are living in the 1960s, maybe. Then my major hospital upgraded to no, I got another job when I moved, and now we used Senna. I was like, wow, why were those people actually using Meditech? Meditech is so archaic. Senna is the best.
Wait for Epic.
And and in less than a year, my major hospital now switched to Epic. At first, everybody we were grumbling. People said they were going to quit the job because this is bullshit. Nobody's going to learn this. It's a lot. But lo and behold, Epic is the best thing that ever happened to electronic health records.
Yeah.
What am I saying in essence? When you work in a hospital, what they use might be different, but the rest assured that you will most likely have electronic health records in place. This helps. It makes documentation easy. Imagine rather than saying, okay, yeah, this patient has a central line. Uh, this is the date it was inserted. This is the location of the central line or the peripheral IV. I changed the dressing. Rather than typing all those things, you could just respond to those things by clicking. Just click, 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 and then you're done. It saves time, basically. It helps that standardization we're talking about. It promotes standardization. And this electronic health record actually does not only refer to Epic, like the computer system, maybe Epic, Meditech, or Senna. Your glucometer could be a source of electronic documentation. Let me explain this. You pick up a glucometer. Before you use it, you scan your badge or your barcode. That is your signature. You scan the patient, you get the blood sugar reading or the blood glucose reading, you dock it, it saves it on that patient's record. When you go on that record, let's say the blood sugar was 92, you go on it, you are not seeing only 92 there. You are seeing your name. When you dig deep, you will see your name there as I took this blood sugar reading, which means your glucometer could be a form of electronic health record. Here in America, I put a picture on this side. This is a picture of Pixies. That's what most hospitals use. I want to believe. I've been to three at least, and I know this is what they use. It might vary a little bit, but basically, so with these Pixies, you go in there, it helps, it reduces chances of medication errors. You have different, I wish I had a bigger picture. You have different cabinets in it. You click a medication from the screen. Before you click that medication, you have used your thumbprint, your fingerprint to get in, which means you have signed that at this time I'm on it. You get on it, you want the medication, you select the medication, the drawer, this particular drawer or the cabinet opens for you, you pick it up. Once you are done, you lock it, you sign out. A week from then, 1 year from that time, they can get on that system and see what you took out at that very time. They could make a printout of such, which means that is a form of electronic documentation. So the Pixies is not just there to dispense medications for you. Let's look at this scenario. Uh, you have a patient who needed a controlled drug. Here in most places, controlled drugs are not witnessed. You don't need independent check. How do we call it this, NC?
I
I
like a
think
witness.
yeah, like a witness, I think is it independent check or something. You don't need someone to come and witness that you are getting this medication. I worked in the UK for about 2.5 years. The way we do our control drug there was different. At least my hospital where I worked, we had a long list of medications of control drug. You get in the morning, you check, you count and see which is missing or if what you have on the record is the same thing what you have in the cabinet. And then when you are picking a medication, let's say you are getting maybe pregabalin, for instance, you need someone to come and witness that there are 20 capsules of pregabalin in there. You are taking two, and the total left is 18. So you need to go and call someone to come and witness you do that to confirm that this is what this person has said. I am there. That person will also sign on the paper. Imagine that person was maybe busy or you you were in the middle of something with a patient or catching up with your own documentation, or then someone comes in to call you. That's distracting you from what you were doing. Here it's a bit different. You only need a witness when you are wasting a controlled drug. I don't know if it is everywhere, but in the systems I have been, that's the way it works. So it's kind of automated, you know. If I go in there, I want to pick up a controlled drug, I open it up. The first thing I do is to count how many I have there. Let's say the quantity is 10. So I put in the number 10. If that is the expected quantity, then I can pick the number desired. Let's say I pick up one pill. Therefore, how many should be left? Nine. The next person who wants to get medication from that same cabinet will start it by signing in, select the medication, then it will ask you for the balance. It should be nine. If it's less than nine or more than, if there's a discrepancy, that's an issue. In that case, you don't actually need to go and call someone to come and check, oh, there is nine here, or do you understand what I mean? I'm just trying to explain to us the essence of electronic documentation or electronic health records, especially with the Pixies. But if you have to with some of this medication, then it's different because I want to give probably 2 milligrams of morphine, of IV morphine. Then I'll get someone to come and the whole vial or the whole ampoule has 4 milligrams. Therefore, I'm going to give just half of it. To confirm that you are not diverting drug, to confirm that you are doing the right thing, then you need a witness in that situation. If I was giving the whole 4 milligram, I don't need anybody to come and verify with me. It is you and the computer, basically. Anyways, now imagine you get to the Pixies, you pick up morphine of 4 milligrams for a patient. You go into the patient room. Before you got there, this patient was actually complaining of pain. The patient was telling you, "Oh, my pain is my pain is 17 out of 10."
Mm.
When that happens, I just tell the patient, "Okay, don't worry. I'll take the 7, you keep the 10. Or I'll take the 10, you keep the 7." So you get there, the patient telling you a pain of 17. What do they want at that point? Get me that medication as soon as possible. It happened to me. I actually give the medication. I scanned this, I did everything. But because the patient was in a hurry, I gave the medication after confirming. But I forgot to complete my chatting on the phone because I'll talk about that later on anyway, so I don't stay too long on this slide. And I think 3 days after, my manager called me, says, okay, now the Pixies has recorded it that I took out that morphine. After taking the morphine, I should go and administer to the patient by scanning the patient and scanning the patient, I mean the medication as well, and select given to show that yes, I have given it. But now I took it from the Pixies, but on the patient chart, it's not there that I gave it, which simply means where is the medication? Do we understand that? Remember, you have signed on the piece that you took it out, but you didn't sign that you gave it to the patient. Then you have a query to answer. There are things you can do to prevent such things from happening. You need to, like, you master the skills along the line. So that's one of those things. I'm just trying to explain that our pixies could be a form of electronic health record. And even the vital sign machine could also be, before you do vital signs in some locations, you scan your badge, you scan the patient, you take the vital sign, then it records, it enters the patient's record automatically with your signature, with your name. When they review it, they see your name as you took that reading. If you're documenting something wrong, you are responsible. Now, in some cases, you don't have to actually do the clicking and clicking. You might have to do some typing. Probably something unusual happened. You want to put in a note. There are some formats. The first one here is a SOAP note that says you talk about the subjective. This patient subjective, the patient's record or the patient's information. Patient says I'm in pain of 17/10. objective. What you saw when you went to the patient was smiling. Your assessment and then the plan. That's talking about SOAP notes. That's a method, that's a format of documentation. You could also have the narrative writing. The narrative is talking about that's the commonest one we did back home then. Patient is this, came in like this happened. Like you're just giving a chronological story of what happened in this situation. There could also be pie chart method, which is talking about you are focusing on the problem, what intervention you did, and the evaluation, that is the outcome of that intervention. I think I have about this three more slides and we should be done. So here we've got legal risk, errors, and best practices. Documentation is a legal record. We have talked about that. It is a Joint Commission standard. It's a CMS standard. This is a Board of Nursing standard. What are common errors in documentation? Late entries. Remember I talked about that one earlier on. You need to make it as timely as possible. If I did my morphine situation, for instance, if I did my morphine situation as timely as possible, that error, the query will not come in. Common errors, missed entries. That was an example of a missed entry. There could also be copy paste inaccuracy. Because it is electronic, you have a tendency to copy and paste. Sometimes you may copy wrong thing. You may imagine you had a patient 3 days ago, and now you come back to the unit, you have the same patient. In the bit of being lazy, you decide to copy your what you enter for the same patient 3 days ago. Be informed, this patient might have had some changes in the condition, but you just copy the whole thing from 3 days ago and slam it on your page or on your column today, which simply means copy paste inaccuracies happen. Remember to also use approved abbreviations only. When you use unapproved abbreviations, those are common errors. And best practices, real-time chatting as much as you can, as timely as possible. You need some ongoing education to help you. And you don't chat ahead of care. Because it is electronic in most cases, once you chat it, it is there. If you delete it, it's going to show that you have deleted something. Imagine you have a patient who is probably end of life, and then you assume you're going to do something in the next 4 hours. So maybe 2 hours to that time, you documented it that, oh yeah, this is done for this patient, and probably repositioning, so to say. That's one of the basic things. And then before the 2 hours elapses, this patient is gone. The patient expires. What will you do? You have to go back to the chat. No, you have two options. Either to leave it as that, that is, you are caring for a patient who expired. Patient expired at 2 p.m. and then your chat says you did something for this patient at 4 p.m. You can see there's discrepancy there. The other option will be for you to go back in there and maybe modify it, which will eventually show up as you have altered the entry. So the best thing to do is you don't chat ahead of care. You don't chat in futuristic terms. So to say, you chat like timeliness. What you have done or what you are doing is what you should chat, not what you intend to do. And of course, you need to avoid some subjective or derogatory language in your documentation, because in some cases or in most cases, these patients also have access to these records. So if you put some negative words, if you put some derogatory words in there, they have access, they will see them. Some of them, while on the hospital bed, have access to their charts, their records, they see their labs, they see their entry, they know what's going on with them. In conclusion, we've talked about culture change, clinical transition. It's just talking about change is constant. And this culture shock is a normal part of a transition process. It will happen. Preparation, education, patience, and constant practice will help us to be successful in integrating professional confidence. Thank you.
Wow. Thank you so much, boss. Thank you, thank you, thank you. This is I don't know how to tell you guys, very, very informative, very, very educative piece of art right there. Thank you so much for this wonderful presentation. We have over 140 people on the course of this presentation listening from different part of Africa and I think some part of the US as well. So we are so excited that you were able to, do justice to this. If you may, please kindly, remove the share so that we can now see ourselves and ask some questions. Thank you so much. Yes, it's done. All right. So now I know that a lot of people have listened to us. So on the comment section, I just want to see if you really got value for the time that you listened for this program. I want you to type value on the comment section. Just type value. I want to see your value on the comment section. And while you're doing that, I have a beautiful, beautiful story about documentation that I would just want to tell you. And it's a dilemma. And I would like to hear from the floor first. I'll hear from you guys. I'm going to test your knowledge to know if you actually understood what he was talking about. So listen to this story. So a doctor who is very, very familiar with a charge nurse made an error in site marking. So he's supposed to mark the left leg and he marked the right leg. And he has already talked to the patient, marked the wrong leg, and then went into the changing room to change his clothes, and then afterwards maybe take a cup of coffee before coming to the room to start the surgery. Because in the US, I think even in Africa as well, the surgeon does not come in until the room is ready. When I say room is ready, I'm talking about the operating room. So the room is ready means that you know, you're gonna get all the teams ready, like anesthesia will be there, the nurses will be there, the surgical tech will be there, the surgical assistant will be there. They will clean the patient, they will put the patient on the bed, they will put tourniquet, they will do everything. So surgeon just comes in, opens his hand like he washes his hand outside, opens his hand like this, wears the gown, just go right to make a cut. So that's where their journey begins in the OR. So majority of the surgeon do not come into the OR when you're in your preparative stages, like, trying to gather supplies and everything. They are not concerned with that. So this surgeon has already, marked the wrong side and went away, maybe to chat with some people and take a coffee, go to the cafeteria or something like that. And then the surgeon was called. Hey, I think the surgeon was very observant. She found out the mistake and said, hey, I think you marked the wrong side. He said, don't worry about it. Don't worry. Just go into the room. And when I get to the room, I'll mark the right one. Okay. And then because they were close, like the surgeon and the charge nurse situation, they were very close to each other. So the charge nurse said, okay, no problem. When he gets into the room, he's gonna make sure he does the right thing. So he's on him. So the charge nurse carried the patient to the room, and the charge nurse, remind you, the charge nurse is not the OR nurse. The OR nurse is different. So the OR nurse is right there in the room. They brought the patient to the OR nurse. The OR nurse started with putting the patient on the bed, and then afterwards, the charge nurse has gone away, right? At that point, charge nurse is no longer in the room. And the only guide at that point now is the site that was marked. So the OR nurse saw the site that was marked and cleaned the site that was marked, because any place that is marked is the site for surgery. So clean the site that was marked. Okay. So after cleaning the site that was marked, the surgeon came in, forgot about what the discussion that they had with the charge nurse, and was already ready because the leg is already prepped, was ready to start the surgery. Okay. And boom, started trying to make a mark, and then the charge nurse appeared and said, I think you're missing something. What's happening here? Wait, 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 wait. And they caught that error, but they all got dinged for it. Like they all got queried for that. So both the doctor, the charge nurse, and the OR nurse, the anesthesia, everybody got got dinged for that situation. But who is to be blamed? Who is the culprit of this whole thing? I'm asking you, just so I know if you understand the concept of documentation. Who is the culprit? Who is supposed to, hold the line, discover the fault, hold the line, and say nobody should make any move? This right thing needs to be done. It's a clinical dilemma. This is the number one I want to let you guys know today. So I want to see your answers on the comment section. Was it the surgeon? Was it the charge nurse? Was it the OR nurse? Was it the anesthesia staff? Who was the culprit? I'm looking at the comment section, guys. Keep your answers coming. I want to really see if you guys got value, like you said, from this meeting. All right, so someone said charge nurse, charge nurse, charge nurse. Everybody's blaming the charge nurse. Only one person said the doctor. One person said the surgeon. Everyone is saying charge nurse. Come on, be nice. Be nice to your fellow nurses, guys. Be nice to your fellow nurses. What's going on here? What is really going on? Why is everybody blaming the charge nurse? Okay, everyone is saying charge nurse, and then I have some few people that said all of them, like all of them needs to go down for it. I'm asking for the person that is the culprit of this whole thing. Okay, who is the culprit? Who is the person that you know? Whatever happens, you shouldn't even be forgiven. We shouldn't forgive the person out of the whole team. The person supposed to hold the line and say, "I'm not letting anything proceed from here except the right thing is done." So everybody says charge us. Someone said the one that discovered it first should have made sure that the thing was corrected. Okay, but he was not the one that made the mistake, right? He didn't make the mistake. The surgeon made the mistake and marked the wrong leg. You understand? So this is also part of documentation. One thing that you guys forget is that the charge nurse discovered this, and the charge nurse did not communicate, did not document. So no matter what happens, if the charge nurse has gone into the chat and made a note and said surgeon marked the wrong leg, and have communicated with the surgeon to correct it, and he decided that he would correct it in the OR. If that has been the case, then it will absolve the charge nurse from anything. But that documentation didn't happen because of what familiarity. They were so close to each other. They loved working together. And one thing about the the US hospital is that it's fast paced. It goes like that charge nurse may be dealing with 5 patients in the pre-op unit. It might be dealing with 5 whole patients in the pre-op, like, trying to coordinate 5 different patients, trying to make sure that all of them gets accurate, diagnosis, everything is documented, the lab works are done, trying to make sure that, there's a lot of things, piece of information here and there that they try to gather. So you may not have the luxury of time to follow up a surgeon, but that is not an excuse. That is not an excuse. So I just wanted to see what our guest will say about this situation, and then we'll ask our question afterwards. So if you have any question that you want to ask, so you can use the reaction button and raise your hand up, and then we can answer that question, and we'll go from there. So Sammy, what do you think about this clinical dilemma? Where
Thanks,
did we
boss.
miss it? Where did those people miss it?
I think it's when you talk about safety, everybody is involved. They my in my hospital, I forgot what it's called. Like you take a second, like this last second before you actually act to verify, to confirm what you are doing, to ensure you're doing the right thing. So at that point, every member of that team present there has the responsibility of verifying, of confirming what was to be done. Uh, imagine the OR nurse there. Of course, before the patient got there, they have a record of this is what they're gonna do. Let's say open reduction and internal fixation of the right femur, and then the surgeon has now marked the left femur or about
Mhm.
to dissect the left femur. The OR nurse could have said, "Oh, so this is like it's called a surgical timeout, I think.
You're right.
A
You're right.
surgical timeout. whereby you take the last minute to confirm what you are doing. This is what we are doing. This is this patient. This is the leg. Uh, do we understand what I'm saying?
Yeah,
We have
you're
marked
right.
this
Yeah.
and so on. So
Mhm.
I think it is a collective responsibility. Yes, you could try to say, okay, this is the perpetrator. But remember, the culture of safety, the safety culture is collective responsibility.
Yes.
Thank you.
You are so on point, sir. You are so on point. It's everybody's responsibility. No one is to be, absolved from that. I remember a hospital back then in my home country that they had a surgery, very nice surgery. They finished the surgery. All of them forgot a tourniquet on the leg of the patient. And guess what? All of them were fired. Both the surgeon, the anesthesia, the OR nurse, the scrub nurse, everybody was fired for that. So it's everybody's responsibility. Safety is something you don't joke with here in the United States. You can lose your license because you failed to observe your surgical timeout. It's one of the red lines that you don't cross in the operating room. Okay. So yeah, so I think that answer was appropriate. Thank you so much for that. And then if you have any questions, somebody named Zoom user has a question. You raised your hand earlier on. You can raise it again. Please kindly rename yourself. If you rename yourself, it will let us know how to address you when we are calling. We don't want to call anybody Zoom user. All right. So please, if you have any question for our guest, kindly raise your hand. We can give you the opportunity to ask the question. And then someone is saying charge nurse, but she identified the error first, but didn't speak up for the patient. Yes, I agree. And then another person is saying, how about patient who is unconscious? Yes, even if patient is unconscious, that's where you become the patient's advocate. And then you have to make sure that the right thing is done for this patient, even when they cannot make their own decisions. All right. So and someone else is saying, how about the WHO checklist, the surgical checklist? That's what our guest was talking about. That's a surgical timeout checklist. It has to be observed in different places. It has to be observed, and then when you get into the operating room, and then you get into different operating rooms, especially across the country where you are, and even in the US, you find that people observe it differently. A lot of people rush through that WHO checklist. The standard WHO checklist should take you about 5 minutes to finish. But people, because of time, no surgeon has luxury of time before surgery to wait and then ask everybody, because it also includes introduction of every member of staff, even though you know them. Even though Sammy, you have to say, Sammy, introduce yourself. You can't keep doing it, and you have like 5 cases every day, and you have to do an introduction on 5 times in a day. So a lot of people modify it to suit the workflow in different hospitals. And when they do that, it kind of impairs the outcome and the goal of that WHO checklist. So just to mention it right there. So I think I see a question. It say in the UK, there is something called LOC SIPS, Local Safety Standard for Invasive Procedure, which is a checklist that must be run through before any invasive procedure. That's very appropriate as well. So someone says, please, what do you think about uploading your draft saved? Let me see. I missed that. Uh, your draft saved 15 minutes of your handover time, handing over time. All these are in your bid to beat time and hand over to a in time in order to keep the next shift nurse wait in order not to keep the next shift nurse waiting. I understand that a lot of people do that as well. Like you have a slip that you can just give to the oncoming nurse so that the person can read and understand what was going on with your patient. And then this shift is something that you have written maybe throughout your shift, everything that happened. That way it provides clarity for the person that is coming to take over. That is a good one as well. So what's the nursing care situation in US post the ban? So yeah, so post ban, so nothing has changed so much. The only thing that we have a lot of states that are striking. So we have a lot of states that are experiencing very crucial, critical staffing problems, right now. So we're believing that that will necessitate a change like a modification in the nature of the ban, at least to allow healthcare workers who play a major role in U.S. healthcare system to be able to come into the United States. That's where it's going to go. It has happened before where special visa considerations were made for healthcare workers. And we're expecting that when the staffing situation crunches a little bit more, we would have such happen in the United States as well. So someone else is asking what happens if you give a controlled drug and you find the wrong number of the remaining drug. Okay, sir. I think Sammy would take that as well. Okay, Sammy, over to you, sir.
Right. Natasha, thank you for that question. Like I said, that's a form of documentation. So let's run a scenario. I want to pick up a dose of, let's say, a controlled drug, let's say oxycodone. I got there, I found 10. Before you pick it, the first thing is after you sign in, the first thing, after you select the patient and then you select the medication. The first thing is it's asks you for the balance. How many can you see there? I'm the first nurse. I put in 10 as the number seen. If it is wrong, it won't let me proceed. But in this case, it's right. So it allowed me, I picked up one pill. And the next person that comes in is Boss Decency. Now, he wants to get in. He counted it. If he finds 9 there, he's going to proceed because that is expected. Remember, it was 10 before me. I took one, it should be 9. But when Decency got there, he found 8. If he enters his 8, the system won't allow him to proceed. He should give him a second chance to verify the count. If he counts it and it's still that same 8, he's going to enter the 8 and he will have to resolve a discrepancy. Then that will involve the charge nurse. There is something, of course, the charge nurse is now involved. You have seen it, you've counted it, it's 8. Therefore, there is a missing pill somewhere. Who is responsible? Don't forget, when I sign in to pick up my own, technically, I have signed my signature is there electronically that I took this medication. Before I took it, it was 10. I took one, it should be 9. But when the next person got there, they found 8. Therefore, I will have to explain what happened. Of course, decency who is speaking, who is also picking the medication, who found that it's 8 instead of 9 and raise a discrepancy, will explain, okay, I found 8, this and that. And in most cases, there are cameras in the pixies
Yes, looking at you right there.
looking at you.
Mhm.
So I hope that answers the question. In my first location, my first assignment here, I had a Nigerian friend. We were on the same unit. We came from the UK together coincidentally. So we picked up a medication from the pixies. We administered it. She witnessed the waste. We administered it. And days after, I got a message from my manager saying this, that, this, that the medication was missing. I was like, no, that didn't happen. I signed it with this RN. They called the RN. The RN also verified. Because we know because we did it, we signed the medication, we did the right thing. But things went wrong. I'm sure they must have actually investigated. But since that day, I made it a point of call whenever I got into a Pyxis to waste any medication which is controlled. I deliberately turn towards the camera so that the camera can see me in case they want to come and investigate anything later on. And it's been working for me. So it's part of me. It's habitual for me. Once it's a waste, I make sure I tilt myself so the camera can see me just in case anything happens later in the future. And I hope that answers your question.
Awesome. Thank you so much. That's a good one. That's a good one, my brother. So see, he did not. So if you are trying to cover, because a lot of people pilfer drugs, like they steal drugs, control drugs. So let me tell you guys a story. There's someone when I was working in the OR, we came to work early in the morning. We're setting up the operating room, and anesthesia. They do have a drug tray which has a lot of fentanyls and all that. So the anesthetist I was working with just went into the restroom. He came in, he was setting his place, and later on went into the restroom. And we were ready to roll back to the room. We couldn't find anesthetic and the CRNA, the anesthetic nurse. We're looking for him everywhere, couldn't find him. And something just told me, just go to the restroom. Maybe he went to use himself. I went there, lo and behold, this guy was lying down on the bed, on the bathroom, unconscious. I just saw his leg, coming out from the door because the bathroom here, the doors are like half door, half up, half down. So it just covers you or whatever. So this guy was lying there, his leg was coming out. I reported, everybody came, overdose. He went there and took some shots of medications. So it happens. A lot of people steal drugs, like they prefer drugs. Not that they want to, but they are addicted to it. Drug addiction is real. Okay? So just make sure that your path is clear. Make sure your path is clear when you leave work. Okay? Yeah, go ahead, sir.
Yeah, just to buttress that, another incident, some of these people, some might actually be dependent on that drug, that they're addicted to it. Why some, these medications are cheap in the hospital, but outside there, on the street,
Mhm. It's
those
gold.
medications are gold. Do you
Gold.
understand? I worked somewhere before, a child nurse was fired. Guess what happened? Just like your question about discrepancy in control drug, a colleague of mine went in to pick medication, or I think they were doing, oh, like we did in the UK then, or like we do control drugs, you count how many, you do like a stock check. We also do here. Sometimes they do a comprehensive check whereby you do everything in the pixels that are controlled drugs. But in most cases, that's usually once in a week. In most cases, you get on the pixels, you double check medications that have been used on that shift only. Like the control meds have been used on that shift only. I think they were doing that, or she wanted to pick a medication, and then I think it was morphine precisely. They got there, they counted, it was less by one. Surprisingly, she saw the charge nurse with the one vial of morphine stuck in between his finger. My colleague was expecting the charge nurse to probably, I'll turn it to a joke, like, oh no, I was just kidding, this is it, or something. And this guy insisted until they resolved it, like it's a discrepancy. That is, a vial was missing, like I explained. Eventually, she wrote her own report. The child wrote her own report. I guess they must have gone back to actually investigate and they realized what happened and they lost the job. That's how bad it can get.
Yeah. That's true. Even the someone was asking me to finish the story. The guy lost his job on the spot. Another person came in, continued. That's the security were invited. They walked him out of. They first of all resuscitated him because he was already unconscious. They had to resuscitate him, gave him fluid, and gave him drugs to reverse the effect of the ones he has taken. And then when he recovered and okay, let's go back to the OR, they said, no, that's the end of your job. Security came and took him out. That's the end of his job. So always watch out, watch your back. When you come here, try to watch your back. Nobody's gonna watch your back for you. So watch your back. Someone is asking, boss, you mentioned about securing license post NCLEX. Can the license be renewed? I think you mean like revoked. Yes, it can be revoked. And I'm going to tell you a story again about someone who just lost his license. I think we'll end there. So since one has gotten a job and is yet to migrate, will Okay, renewed. I mean, yes, your license will be renewed after I think every year. Some states are different. It depends on the state, but Texas Board of Nursing, depending on when you did your registration, you might have just like 1 year, or some people get like 6 months and they have to renew. Okay, we do not lose his license for not renewing. You don't, but it remains inactive until you renew it. All right. So there is a nurse in Virginia right here. Is a CRNA, which is like a nurse anesthetist. And because of I don't know if you guys have been following the news about ICE, because of the ICE situation, and this lady is trying to grow her social media. And I always say it on this place, please. I say it every Friday. Free, there is no free speech again. No speech is free anymore. You understand? Don't say because it is free speech and it's not. Just be careful of your social media. Be careful of what you say on social media. So this CRNA nurse went ahead to her social media and just said that, hey, I just thought about something. Why don't we just, all the CRNA people, why can't we just draw up paralytics and just put it in our bag and go for protest? And when the ICE people come to us, we can just give them a shot. She said that casually and jokingly, but that was not a joke. That was a threat to human life. And guess what? Her license was revoked. She lost her job. If you go on the internet right now and say Virginia nurse that made a joke with paralytics, you will see her. It will come up. She lost her job. Her license has been revoked. This, for you to get a CRNA license is a struggle. You have to go to ICU and do like 2 years, and then you go to school without having any option to work for 3 years, and then you come out and become a CRNA. That license went into the drain because of the quest to grow someone's social media handle. So, my dear, it is not worth it. You understand? It was a joke. And she has been saying it is a joke. I was just trying to make a joke, but they didn't take it as a joke because as you're making that joke, someone else can take it up as a life mission to do it. Okay? So that's just to say in passing, be careful of what you say, be careful of what you do on social media, especially now that you're yet to come here, because some of these things are being reviewed by the Department of Homeland Security at the point of entry. They will ask you your name and then they will go on the social media and review your page. You understand? You might be rejoicing you got a visa, but there before you come in, something can pop up and it could be a game changer for everything. So kindly, carefully monitor your behavior on the social media, pre, intra, and post arrival. All of that should be in moderation. You shouldn't be taken by emotion. No matter what is happening out there, don't move by emotion. You understand? Don't move by emotion. Just know that um, there is no free speech. Okay? So thank you, everyone. I think we answered all the questions that they asked, that was asked. Okay. I want to ask again, if you guys got value for what has been shared in this place, one of my major take homes is about when he talked about building networks, building networks. Building networks is very important. When you come here, do not forget, there are people that has been here before you. You have to, bend down, be humble enough to learn from them. Your hospital is going to organize like an orientation session for you. Make it an opportunity for you to learn. Don't say I know it all, no matter the kind of hospital you're coming in from, because here they have so many equipment that you might not be familiar with. So when you come here, bend down, learn. When you learn the job, you become like a god of your own. You can decide how much you get paid. You can decide what kind of work you can work. If they don't want to, if they can't pay you, then you move to the next job. You understand? That's a lot of things that people do right here. And travel opportunities are also there for those of you that finish your contract and decides to go into travel. So with that, we've come to the very end of this meeting. I would like to bring the meeting to a close, but I won't do that without thanking our guests immensely, immensely. You guys don't know how much I appreciate this guy, for taking our time out of his busy schedule to be here, sacrificing his sleep, sacrificing his sleep. Come on, my brothers and my sisters. His reward, watch out for him. His reward is in this earth. He's going to get his reward right here on this earth, not in heaven. You will get in heaven, oh, but you will get it from here on this earth. So, my brothers and my sisters and everybody here, I want you guys to say thank you to this wonderful personality in your different languages. We always do this because we have a lot of people coming from different places. Someone called you a name that I think I'll be calling you every time. He said you are a fountain of knowledge. I think that's going to be your next name. Okay, Sammy. Sammy, please, you're going to help us to read all the comments in the comment section. We are all saying thank you in different ways in our different dialects and different languages. So let's see you try some
Okay.
of those languages.
So,
And please kindly mention the state or the country where the language is coming from. Please. Thank you. Sammy, over to you. Your test begins
to
now.
our to our tola, to our totela. Oh, that one weak me. Oh. Kenya?
Kenya.
No, I don't
Okay.
know. Oh, Brigada. Now, Two-Face singing for something.
Now that I don't know. Now your test, you won't collect answer from me. Ah,
Oh,
okay.
Brigada. Is that Italia? I don't know.
Guys, keep it
Eshion, that one
coming.
is my language. Eshion, that's my own language now. Thank you. That's a English language. Eshion, wow. Eshion. This
Guys,
one now
keep it
typed as if
coming,
it's a
guys.
different dialect. Dalu, that's Igbo.
Mhm.
I know that one.
Keep it coming, guys.
Sonsongo,
Keep it coming. Different
Nkoya Jaja.
countries. Keep it coming.
It's Sonsongo. Is that Zimbabwe? This is real test, man. Mongo Day. Nago Day. Mungo Day. Hausa.
Yeah, you got it.
Shukra. Oh, that's Saudi. I would have said Shukra. Like I remember when I went to Philippines.
Mhm.
I think I went with Etihad, so I had Shukra, Shukra.
Shukra, shukra.
Yes, thank you. Adukbe, Esheun, Dalu, Igbo. Hey, yeah. Calabash of wisdom.
You are a calabash of
I'm
wisdom.
honored, I'm honored, I'm honored. Oh, Brigada Portuguese, really? I'll add that to my full of
Wow, that's a
vocabulary.
nice one. I didn't even know
Thank
that.
you.
Mhm.
Wow.
Brazil.
Thank you. But Chioma, you be Igbo now.
Maybe she's living there.
Oh, yeah, yeah. Wow. That's interesting. Thank you. Tortilla is Zambia. Oh, Chukwu gozie gị. Yeah, Igbo, yes, no. Ngode
Okay.
Hausa. I got that.
Yeah. All right.
Even Uwese Kakabo. That's Uwese should be maybe Calabar,
Middle
Cross
belt.
River.
Middle belt area, I think.
No. Uwese. This one are Urobo. I don't know about Urobo.
Urobo. Yeah, I think,
From the
yeah.
spelling, from the
Yeah.
spelling. Anyway, this is great. This is interesting. How are you able to manage 12 patients and still maintain a timely documentation? Oh, I think I need to answer this one. I said currently I'm in my best nursing era. I had 10, 12 patients when I worked in the UK. That's almost a norm. I didn't work in a care home or nursing home where you have very high numbers. No, I work in a hospital. Like that's the base. 8, 10, 12 patients. And back then we didn't use electronic record or electronic documentation. It's more of paper charts. You use electronic to look at lab results and so on. So the doctors then always documented in notes and so on, PT notes, OT, nutritionist. So that was in the UK. Here, my first assignment here, I had 6 patients, between 4 to 6 patients, but usually 6, 5, 6, but never about 6. That was in Corpus Christi in Texas too. And then I moved down to around Houston uh area, and it's been 3. And in some cases, I have just 2. Imagine getting to the unit, you have an open bed. Out of 3, you have an open bed, expecting an admission. One of the two was even discharged. Then you now get one later, maybe like 1 a.m. So come on. In such shifts, I assume I won, not my hospital. Sometimes my hospital will win me. We go again, you know. I hope that answers the question. Danke. Hi. Borno. Barca. Ah. See, boss, you
Are you
don't know this
tired?
language is too much, oh.
You're
It's
tired of the
really.
languages.
Ah. But no, I
Okay.
appreciate the diversity. I appreciate the diversity. And I think I need to just say, boss, I really appreciate you. I don't know, most of you probably ran into decency in this process, just like me. I was looking for fingerprint cards, and then I got in touch with decency. Since then, I saved his number. We talked. I uh he has my number, so I see his status while I was in the UK. I have uh First Lady's number as well. She sees my status, I see her status back then. And I must appreciate, sir, you are doing a great job.
You.
You like to gather people from different spheres, different location, charm the same cause at no cost. You are doing this, gathering people, your time, your don't let me use your line that your reward is here, but I'm sure God will reward you. Your labor will not go in vain in Jesus' name. I can see it,
Thank
it's
you.
evident. So I appreciate the growth.
Thank you.
More
Thank you
power,
so much.
boss.
I
Yeah, yeah,
appreciate
yeah,
you. Thanks a lot. All
yeah,
right. So
yeah.
at this point, we are going to bring the program to a close, and I will see you guys next week, Friday. Next week, Friday, we'll have a nurse manager in Florida. He's also a registered nurse from Nigeria. She immigrated like every one of us. Went there, had excelled excellently. You know, she's somebody that if you talk about excellence, she stops at nothing until she gets what she wants. So she's going to be here next week, Friday, to give you guys a piece of her own story and how she came to the United States and went from being a floor nurse to being a nurse manager. I'm not talking about a charge nurse. I'm talking about a nurse manager. So look out for that presentation on Friday, and I will see you all on Friday. Thank you, and God bless you. My boss, thank you.
Thank
God
you.
bless you
Bye.
so
I
much.
appreciate it,
Yeah.
boss. Yeah, yeah.
Bye,
Bye.
everyone. Bye.
Bye, guys.